Thank you for asking me to be here again. What are the kinds of things that we as medical oncologists think about when we're trying to treat patients, when we are monitoring patients, when we are designing the next set of research studies and research questions? Because really what this is all about are moments, right? There's moments in life where we kind of have a sort of an aha moment, and that moment could be the birth or marriage of a family member or the death of a family member, hopefully at age 150 when it's supposed to be in life. But there are moments perhaps when people are in a doctor's office and they're told that they have cancer. And maybe some of you remember those moments either personally or with family members, but those moments where suddenly being tired isn't just about being tired. Or as one person told me the other week, well, my doctor told me that since I was 40, I should be tired. And as someone who clearly is only just maybe 5 minutes older than 40, at least several years ago I was, there's oftentimes times when tiredness can just be tiredness. But there are moments when tiredness can become cancer, and that's either oh, finally I have an answer, or it could be a moment of terror, where the word cancer to many people means either it's going to be removed surgically or I have to drop dead in the next 5 minutes. Or maybe even if it is removed surgically, I have to drop dead in the next 5 minutes. And I'm exaggerating on purpose because all of those thoughts go through all of our minds when we hear the word cancer. And really what I hope to show you is that there's a lot of middle ground between that moment where you hear that there's a cancer and that moment where hopefully after a very long and rich life, one might pass away, and hopefully not from cancer. So I think that conversations about oncology are really about individual people, right? We can talk about studies, and we will, and aggregates and populations and healthcare dollars and all that kind of stuff. But what I'd really like to do today is remember that the treatment of cancer is really the treatment of individuals. And how do we figure that out? You've heard a couple of mentions about these subtypes of pancreas cancer or the individualization of chemotherapy, and we'll talk about that in just a minute. So here's our person who's 59, feeling a little tired with a little bit of reflux. Go to the drugstore, pick your favorite box, buy that drug, take that drug like everybody else in the Western world, and come back in a year. And 6 months later, he comes back and has diabetes diagnosed. And that's kind of strange because his family doesn't really have diabetes in it, and he's not necessarily the history of the typical diabetic, although whatever that means. He's put on some medications, and then finally a year later, suddenly out of nowhere, develops some belly pain and jaundice. Urine gets dark, skin gets yellow. Goes to the emergency room and then has what we see very commonly, and that is really every single radiologic test known to the radiologist, right? Maybe an ultrasound, maybe a CAT scan, maybe an MRI, maybe a PET scan, and maybe a couple more each time that people go to different doctors. But this time there was a mass at the head of the pancreas with the blood tests or tumor markers here are normal, with the question of what do you do? And I often have cartoon envy of doctors Donahue, Reber, and Hines, but I did manage to find a couple because it sort of illustrates the idea that small tumor, not in a bad place, that's an easy problem to have in the world of pancreas cancer. But oftentimes tumors get a little bit close to the blood vessels or the bile ducts, as Tim was talking about as well. So before we can decide that this person really has cancer, even though it looks like it's going to be cancer, we actually need tissue diagnosis. Oftentimes that's made off of an endoscopy, going through the mouth, going to look at the pancreas, taking a sample of tissue. Fortunately or unfortunately, it's a lot less invasive, I suppose, unless you're the person going through the endoscopy, but it's a lot less invasive than a surgery to get some tissue. But it kind of hurts us in the long run when we can't get enough tissue for what we're going to talk about as molecular or genomic profiling. Not arguing that this isn't the right way to make the diagnosis, but sometimes we sort of have to get people used to the idea that we need more and more tissue, not just to look under the microscope and see what the cells look like, but oftentimes what they look like or what they contain inside. So first stop is with the surgeon who feels that the resection might be possible, but there's a questionable lung lesion in the chest and not really sure if it's cancer or if it's an old disease, with the question of what to do. So Tim alluded a little bit to this, and that is there are criteria that different surgeons are going to use as to what is resectable. People come up with criteria. These are the National Comprehensive Cancer Center Network criteria. And I would echo what's been said already this morning, and that is centers that are used to doing this really understand this the best. You know, there are a lot of surgeons that are capable of doing pancreas surgery, but we really see, given that not all of our patients come from our surgeons, but we really see a very big difference between surgeons who are used to doing this and capable of doing this and study this and live this, and other surgeons who might be doing other things as well. So what I'd like to talk about a little bit is to give a bit more detail as to what was talked about by our earlier speakers of let's do some chemotherapy before, and we call that neoadjuvant therapy. So you're all familiar that doctors have to invent words, and as soon as you all figure out the definition of the word, we will change the word just so that we sound like we know what we're talking about. But neoadjuvant therapy is really the term for we're going to do something before a potentially curable surgery, right? So chemotherapy, radiotherapy, or both. And since a lot of this is borrowed from what we know in more advanced disease that's already spread beyond the pancreas, it will illustrate a lot of the principles of pancreas cancer therapy in general with a little bit more flavor of what we tend to do more often now, and that is the chemotherapy up front. So if we're going to do surgery and if we're worried that the cancer is going to come back and we talk about chemotherapy, radiation therapy, or both to prevent it from coming back, and we flip that a little bit and do that treatment before surgery, at the end of the day, it's really the same thing, right? Theoretically, it's the same thing. And doing it this way gives us a couple of very important opportunities. First, do the drugs work or not, right? Because if we do it after surgery and there's nothing to look for, we have no idea if the drugs are working. So this gives us an opportunity perhaps to judge the efficacy of the therapy, to judge how well someone tolerates therapy. And then the second thing is that, as it's been said so many times before, it makes sure that the person who goes to the operating room is the right person to go to the operating room. If the disease is not going to respond to chemotherapy, and it's one of those things that's often on an ABC movie of the week, that the disease is just relentless and growing and the person is sick before your eyes, that person's not going to be helped by surgery today, and we better figure out how to control the disease before we put them through a surgery and a recovery period that's going to be very, very difficult. So those are the two opportunities that doing therapy this way affords us. So if we're going to do something, we have to ask the following questions. And they're obvious questions, but you'd be surprised how little common sense sometimes leads to therapy decisions, and how little common sense we all have at those moments of terror that I was talking about. So first, will our therapy work? Can we do it? Forget about how much cost it is, but it is a factor if we're sitting on a national health board. But when I talk about the cost of therapy, I'm really talking about the time involved, the side effects involved, what is it doing to somebody's life if we're making them miserable, not to make them better. So the is it worth it question. How long should we do it? And you heard Tim say, some people would say 2 months, some people would say 150 months, but somewhere in the middle is the right answer. Are we wasting time? I had a patient that came in a couple of weeks ago who said, but if my tumor is going to grow, it's not going to be resectable in a couple of months. And the answer being, well, that's really going to happen. Surgery is not going to help you today, right? It's not like surgery today is going to have gotten that tumor that perhaps is going to declare itself by not behaving, by not really responding to therapy. Do we have to give it to everybody? Are we right that chemotherapy up front is really the right thing to do? Which drugs, radiation, yes or no? What does the response mean? If we start to see inflammation, if we start to see that the cancer is a little bit bigger, is that the cancer growing and not responding? Is that the inflammation that can often be seen around the cancer? How much is enough shrinkage? How much is enough time? So all of these are obviously, rhetorical questions, but ones that we really struggle with. On a populational level, it's fairly easy to look at, but on an individual level, to that person across the examination room, that really what this is all about, we have to get very smart very, very quickly. So this is just sort of an article that was published that basically says, if you can get somebody to surgery, And if you're right that they were the right candidate for surgery, they do better. And these are older data with older chemotherapy drugs and with radiation therapy that we don't really use very much anymore, but it just sort of justifies that in a number of centers, what Tim had showed you, that chemotherapy or radiation therapy is helping to select the right patients. All right. So we've all bought into, okay, we'll do it, because the surgeons are asking us to do it, because it makes scientific sense to do it, so we'll do it. What could we do? And it's really quite interesting that this list is longer than it was even a few years ago, and getting longer even as a few months. So you see a list of conventional chemotherapy drugs. I put brand names on because, not that I'm interested in a commercial for some drug company, but sometimes people hear about them as brand names rather than conventional names. And then with radiation therapy, we have more traditional radiation therapy that's sort of daily, 5 days a week, 6 weeks-ish. And then we have the newer forms, sometimes people refer to as gamma knife, cyber knife, or stereotactic body radiation therapy. All right? So one of the combinations, or what we've learned actually from the advanced disease setting, where a lot of this is borrowed from, is that in advanced disease, disease that's already spread or disease that for sure is not removable or resectable, combinations of chemotherapy work. So it took us a long time, believe it or not, to figure that out. It's really only within the past 5 years that that's happened. There was a drug developed, I want to say about 15, maybe even a little bit longer ago now, called Gemzar or gemcitabine. And no matter what combination you threw up against gemcitabine, it wasn't any better, even though everybody said initially in those combinations were studied that we were going to cure cancer. And so other drugs got developed. Fulfirinox is an acronym of a bunch of different drugs together. Folinic acid, or leucovorin, a vitamin that makes the 5-FU stronger. 5-FU, very good name for cancer drugs, wouldn't you think? Irinotecan, CPT-11, and then oxaliplatin. So this combination, very effective against a bunch of digestive system cancers, was tested against Gemzar. So we can talk later if one's interested about how drugs are developed, but suffice it to say that you need to have hundreds, if not more, patients where you're having a computer decide a new therapy versus an old therapy, or old therapy by itself, or old therapy plus something new. And that's a very typical thing that will be taken to the FDA in order for approval. So this was new therapy, Fulfirinox, against old therapy, Gemzar. And it's not that I really need you to pay attention to the numbers here, not that they project so well on this screen, but what I want you to say is that we evaluate treatments in many different ways. The gold standard, of course, is survival. How long will people live when they take different types of therapy? And survival, of course, is affected by cancer and chemotherapy, but it's also affected on whether the car comes through the window and hits you, right? So survival is an important outpoint. It takes a long time to get to, and it's so difficult to measure what's specific to the cancer. So you can see the red is greater than the blue. The new therapy worked better, right? And that's nice that it worked better. Below that is something called progression-free survival. That's a faster endpoint. How long does it take before the disease grows? Now remember, these are people that are not ever going to surgery, right? So at some point, either the drugs won't work at all, they'll stop working, or maybe things will plateau, you'll be able to stop the chemotherapy. If the disease never grows, if the disease goes away, that's a very good problem to have, but a lot of times in oncology that doesn't happen. Again, back to the comment I made at the beginning, the alternative is not you have to die tomorrow. It could be that you could live in concert with your disease, like one can often live with a lot of chronic diseases, and we're trying to get cancer into that category, like high blood pressure, like diabetes. So progression-free survival, how long does it take before the cancer grows? That's obviously shorter. And on the left, and this is what people tend to focus on a lot, we talk about response rates. How much does it shrink? So let me give you a little bit of trade secrets, right? Arbitrarily, response rates mean that the tumor either has to go away, that's sort of obvious, or it has to shrink by 50% or more. If you have 10 tumors in your lung, when you add them all up together, however you measure them, that has to decrease by 50%. So a 49% shrinkage is not a response. I'd probably argue that that's a good outcome if you have a 49% shrinkage in your cancer. Just like if your cancer shrunk by 99% on Tuesday but grew on Wednesday, I'm not sure I care, It's a nice Tuesday, but I'm not sure that I care back to survival endpoints or progression-free survival endpoints. So response is an important marker for how well the person is going to do, but it's not the only thing that we look at. So people have increased these numbers by saying if you have stable disease, meaning the cancer doesn't grow, the trade secret is it doesn't grow by more than 20 or 25%, so between 49% shrinkage and 20 or 25% growth is called stable disease. And obviously those numbers in this case would move up probably into the 60s, maybe even the 70s. That's why people talk about that as a benefit rate. Now response matters in this discussion that we were starting to have about neoadjuvant therapy, because we really want that tumor to shrink to make surgery more realistic and more effective. So response does become an important endpoint to someone that we're trying to get to surgery, and it is obviously important in people who are not going to get to surgery, but in a very different way. Well, what's the cost? Side effects, right? So this is a hard regimen, as some of you may be familiar. So lowering of the blood counts, nausea, vomiting, diarrhea, weight loss, fatigue, neuropathy, numbness and tingling in the fingers and toes, those things happen, and we grade them on a scale, 0 to 5, with 3 and 4 being pretty severe. So a grade 3 nausea, for example, is you can barely eat. You need to have some kind of intravenous nutrition, or you're losing significant weight. So it's not like my tummy hurts, and it's not like I need to pop a pill. It's really significant kind of stuff. And as I've said to people many times before, I will gladly make you sick, as long as I can promise to make you better in the medium term or the long term. But if all I'm going to do is make you sick for you to live 5 extra minutes and be miserable along the way, I'm not so sure that that's a good thing. And so we always are judging what's the cost of therapy, what's the benefit of therapy, and going from there. So the other sexy kid on the block is using that old drug Gemzar along with a drug whose generic name is nanoparticle paclitaxel. Abraxane is the brand name. And you can see that the curves are similar here. And the response rates are less. So Gemzar Abraxane in this group of people who had metastatic disease that spread beyond the pancreas, is about 23%. But there's an error around that, because you can see that the Gemzar people alone were 7% in this group, 9% in that group. So if we kind of make the 31 here in the FOLFIRINOX arm a few percent lower, we make the Gemzar a little bit better, you can see that those numbers are getting very close. So again, benefit rate, keeping the disease from growing or even shrinking it in that 49 or even 5%, which might be enough to make surgery feasible, those numbers jump up to 65 or 70%. So we are doing, I think, very, very well with these drugs. The problem is that we have a lot of room for improvement, and we don't really know whether one regimen is better than the other. So the statisticians tell us that you can't just compare studies like I did. You can't look at 2 different studies. If you really want to know which one is better, you've got to do that big study randomly assigning people to 2 different things. And one day that may be done. There are groups that are trying, but a lot of people are not so keen on having a computer decide for them or on the doctor's side for their patients. So it's a little bit difficult to say. This one's a little bit easier side effect-wise, but again, not a walk in the park either. So the point is, back to our person who has a borderline resectability, if what we want to try to do is maximize the chance to shrink the tumor to get the patient to surgery, and they have a curable disease, and to an oncologist, using the word cure means that the disease goes away and stays away forever, not my Tuesday, Wednesday example, not an only endpoint, as we'll talk about in just a few minutes as well. But if our goal is to get people to surgery, it's my opinion that you have to go with what the literature has already told us in hundreds, if not thousands of patients, and you have to start. So oncology isn't about making a decision and sticking with it, stubbornly until the very end. It's about making the best decision that you can make at the time, and then modifying that decision when you get new information. New information about the world, new information about the disease, about science, new information about how these drugs are affecting this particular person on the good side and the bad side. And so typically, most doctors, when they're thinking about neoadjuvant therapy, are going to be using one of these regimens. In my opinion, dealer's choice, although often people defer to FOLFIRINOX because they're cheating across multiple studies. So indeed, this person had FOLFIRINOX therapy, the lung nodule turned out to be nothing, surgery successful, pathology that you see, completed an additional couple months of chemotherapy because they were on Tim's list of the characteristics that required more therapy, and then that person has moved on to an active surveillance program, and 3-4 years later, free of disease. These are real people. So let's meet T.S., who's RB's neighbor, who because of her friend went for a physical exam. She was diagnosed with pancreas cancer that already spread to the liver and lungs, so it's unlikely at the time of diagnosis to benefit from surgery. She felt a little tired. She had some bloating. She had some weight loss. She had some diarrhea, but pretty much she was functioning in her full-time job as the guardian of the neighborhood news, right? I think we all have people like that in our neighborhoods that just sort of tell us what's going on the street. But the point is that this person was very fully active, and yes, there were some disease-related symptoms, and the scan showed some disease, if not a lot of disease, but the person's very functional. And the common sense version of oncology tells you that if someone looks okay, they are okay. That's not to say that if someone is horribly ill, they're not going to be okay, because you fix the source of the looking ill, they will become better as well. But typically, one of the things that is just so easy to understand and so obvious is that the person who looks and feels well and is able to do more is going to do better. So we talked about some chemotherapy, right? The chemotherapy, as I would define it, would be drugs that are going to kind of kill everything indiscriminately, hoping that the good cells grow back and the bad cells die. Sort of the way we've treated cancer for a number of years. It works in a lot of patients. There are a lot of diseases that are completely curable now. Childhood leukemias, testicular cancers, breast cancers, and some pancreas cancers with chemotherapy. But for obvious reasons, we know that we have to do better. So the drugs that we've talked about, that list that I showed you, are the chemotherapy drugs, and those combinations are used in advanced disease as well. Here's another one that was just approved within the past couple of months, really. Again, that nanoparticle idea that you can get chemotherapy delivered directly to where the tumor is through these kind of stealth bombs. Sounds sexy. In the laboratory, it's sexy. The question is really how much better it is than traditional chemotherapy. But you see irinotecan is one of the drugs that has always been in FOLFIRINOX. This is a same drug, but kind of chemically packaged a bit differently, and now approved recently for pancreas cancer, but still in that chemotherapy kind of way. And again, these are patients who have already had chemotherapy, so their disease is already declared to be a little bit more difficult to treat, and that's why you may see that the curves don't look as nice as the others. So there's still a bunch of unanswered questions. You'd think after all of this time and this many patients, we would be able to have all these questions answered, but they're just not. So to give you an idea, people are really trying to say in earlier stages of disease, right, if the Gemzar-Abraxane combination works well in people with metastatic disease, like I told you, does it really work better than Gemzar by itself in earlier stages of disease? So that study is ongoing and having a hard time accruing. Different combinations of all these drugs, plus or minus radiation versus each other, all of that kind of thing. And what you see sort of in the middle of the slide, these sort of new acronyms. So can we change the way that we deliver these drugs? There's something called FOLFOX-A, which is kind of a little bit of both regimens, and then something called Fablox, which can also be very sexy, using the field of angiogenesis inhibition, the idea that cancers create new blood vessels to feed themselves. If you can get rid of that new blood vessel formation, then you're kind of starving or choking off the tumor. Some of you may remember about 15 years ago, we were going to cure everybody's cancer with this way of treating cancers. I still have a job, fortunately or unfortunately. We still have cancer. The drug bevacizumab or Avastin is often mentioned in this class, although there's a whole bunch of them. When you study bevacizumab in pancreas cancer, it didn't work. And there were huge numbers of studies involving hundreds, if not thousands, of patients in early and late stages of disease. So either the drug doesn't work at all, or maybe we didn't know how to use it the right way, and hence the need still for all of these chemotherapy studies to make sure that we're giving the drugs that we have in the best way possible. So these studies are still going on. And the idea of biomarkers, can we just figure out who needs what? Is there a way to test the tumor? Is there a way to test someone's blood? Is there a way to figure out which drugs are likely to work? We talk about those as biomarkers, and again, it's been a bit frustrating, but people are continuing to try to find those characteristics of cancer that might help us make decisions. And then radiation therapy, again, the same thing. Does radiation therapy help or not? And if we have some time, we'll talk about that in a little bit. Well, we got to do better, and I think a lot of people are familiar with the idea of chemotherapy on the good or the bad side. What about the future of oncology? So this is the idea of personalized medicine, as you've heard many, many articles, many speakers talk about. You want to try to figure out who's going to have more or less side effects, who's going to have a better chance of responding or not, and obviously get the right therapy to the person. I mention this as one of many companies that is looking at what we call molecular profiling, genetic characteristics, protein, proteomic, or gene or genomic characteristics of the cancer. It came up in a question a little bit earlier. The idea that you can take tumor tissue and make a decision about characteristics of the cancer. Right? So that's usually off of a biopsy. It has to be a biopsy that has enough tissue, very hard sometimes in people whose tumors are only in the pancreas. Companies are experimenting about whether to do this off of the peripheral blood or if it has to be tissue. The obvious question, can I take a biopsy from surgery 3 years ago when I was diagnosed, and is it relevant to me 3 years later if my disease came back? Is my tumor in the pancreas the same as my tumor in the liver? Are two separate biopsies in the same tumor in the liver the same, right? These are all questions that people don't understand yet. But nonetheless, the idea is that you do a biopsy, you run it against a panel of 200 or 300 or sometimes more. It's an ever-expanding list. Genes, proteins, characteristics, not things that you're inheriting, not things that you're likely to pass on to your children, which is why we sort of talk about them as genetic or molecular characteristics of the cancer. So Prothera, I include this slide because I think it was the PanCan patient support group for pancreas cancer, where Prothera was working very closely with them to help patients get this done. They analyze it. I'm not sure that they analyze it in any different way than anybody else, and then they give you a report. This is your characteristics of your cancer. These are potential treatment options that might be made available for your oncologist. Foundation Medicine is out of Boston. It's another one that's very commonly used. And again, you get a report like this where you can see that there are genomic alterations identified and whether there are clinical trials. Now here's the challenge with this, right? Number one, all the different issues around whether the drugs are correct or not, or whether the biopsies are correct or not. So sometimes we don't get any information at all. Sometimes we get and identify mutations that we have no idea what to do with them. Tim talked about them as actionable mutations, right? And maybe one day we will learn them. Or sometimes you find that one's tumor has a characteristic that's here that matches very nicely a drug. In pancreas cancer, that is very rare, but it is our holy grail. And the other thing to think about is if you look at one's cancer as a tree, to kill the tree, you want to kill it off at the trunk. Are these mutations at the trunk of the tree, so they really matter, or are they just sort of at top branches where if you cut off the branch, it doesn't really matter to what's most important to each of us? How well is a person going to feel? How long is a person going to live? So this is something that we get on all of our patients at the beginning of their diagnosis, and certainly we think about if the field changes, repeating it again, but it is important. And what you see here as we start to think about these kinds of tests is here's one of thousands of cartoons that have been developed that list all the different things that could be going on in pancreas cancer, how they interact with each other, whether they're important, whether they're not, and where they rank on the so-called tree is really the most difficult thing to do. Aggie had talked about the 4 different subtypes of cancer. That comes from a study, Cancer by Cancer, of the Human Genome Atlas. This is about 500 people with pancreas cancer that were sequenced. And it seems like if you look at these 400 people with pancreas cancer, that they subdivide into 4 groups. That's not to say that each person is identical to their group, but 4 general groups that might be different molecularly. Now, we have no idea what that really means, right? On the bottom of the curve, and I'm sorry it doesn't project very well, but I'll bet that they're going to put this up on a website, is you can see that that blue group perhaps is a worse prognosis group. That might be a group that you want to target differently. But that's not to say that everybody in the blue group does poorly. There are people in the blue group that do very well. So it's just trying to understand, why do some people with pancreas cancer do particularly well and some don't, and some respond and some don't? Are there different characteristics that we could tease out, and then just as importantly, design therapies? So this is just hot off the press, as was said a couple of weeks ago, but not really ready for prime time yet. Clinically, clinically until we start looking and seeing if that can lead to differences in the way people tolerate therapy or receive therapy. So I told you about angiogenesis inhibitors curing everybody 15 years ago. Immunotherapy is curing everybody today, right? And that's because it makes sense. Use the immune system to take care of the cancer. So these are very, very simplistic cartoons. I'm happy to answer questions. Skin melanomas, everyone's heard the Jimmy Carter story. In lung cancers, in kidney cancer, these drugs work fabulously well. The idea is that the cancer is throwing up a decoy to make it hide from the immune system. If you get rid of the decoy with drugs, 2 of them now approved, others in development, then the immune system can see and therefore attack the cancer. And that's the PD-1, PD-L1 inhibitor. PD stands for programmed death, make the cell die, right? And also using the immune system very well to attack the cancer. People are testing it. It's a little bit harder in digestive system cancers. We can talk about why that might be later. But so far, we're not seeing the success in digestive system cancers that we would like, but that doesn't mean that everyone is stopping trying. So I think people are also looking at that drug that we just spoke about, but at the top on the left, good that I'm not a surgeon because I don't know my left from my right, but I know that the L's help me, is instead of just getting rid of the decoy, can we stimulate the immune system? So block the decoy or get rid of the decoy and then come in with something that stimulates the immune system. And that's, again, this combination is the Jimmy Carter sort of combination, works fabulously well in melanoma, but what you do when you do that is you increase the risk of the immune system attacking the normal cells, so-called autoimmune problems. And they can be much more disabling than chemotherapy in some patients. Here's just the original paper that looked at melanoma, lung cancer, kidney cancer. And what you can see in some of the CAT scans, and you can see with the arrows, I'm just flipping a little bit more quickly in the interest of time, is the idea that cancers are overtly shrinking, in some cases melting away. I mean, it's really, really a remarkable, remarkable success in these cancers. And again, people are trying to duplicate that in other cancers and those responding in very long periods of time. All right, vaccines, right? They're sexy. I know that we're in West LA and vaccines may not be sexy to everybody in West LA, but for the rest of the world, vaccines have made tremendous impact in disease. And so it seems right if we can figure out what to vaccinate against. So this is an example of a personal vaccine. Take the specific cancer cells from the patient, raise up an immune system response to those individualized cancer cells, inject that vaccine back into the person, which now recognizes the cancer, kills the cancer. And that's what Dr. Go was speaking about this morning in leukemias and lymphomas, which are diseases of the immune system, wonderfully, wonderfully effective. The idea, again, being here, very difficult to do on an individual basis, and in solid tumors, tumors of the organs, very, very hard to talk about, very, very hard to see success. This is also kind of just an extra step of using something called a dendritic cell, which sort of presents the cancer and the immune system together. And again, you can raise a vaccine against that. Here's a vaccine trial that was very sexy about a year or 2 ago. Turned out not necessarily to be so effective, but those results have not officially been presented. And I think in the interest of time, I'm going to just split to the end, but happy to answer questions about how we think about earlier stages of disease, because it's very similar than what we've talked about already, but you're going to take different kinds of chances with somebody who has a completely curable disease. So kind of the 5-second message, what do? You find the right care team, right? You find the group that are talking to each other across disciplines and that individually you can relate to, make sure that you're getting the answers that you need and you're getting the care that you need. Following curative surgeries, you probably want to do something rather than nothing. You want to think about surgery at the beginning. You want to use your multidisciplinary team, but you always want to use your peripheral vision to watch science, to watch the USA Today, where I get my medical research information from. And you want to just really make sure that you're aware that there are lots of things going on in oncology, some real, some not so real, to help you get from moment to moment to moment. And with that, thank you for your attention. And I'd be happy to answer some questions.